morning, peeps. Well, I guess it's actually afternoon. This isn't even really coffee with the EMS Avenger. It's more like midday with the EMS Avenger. It's cream soda with EMS Avenger. That's what it is. Good morning. What's on the docket today? Well, I posted a video not too long ago that brought attention to 22 correctional officers in Illinois who got exposed to baby powder and Tylenol nasal spray, and all were brought to the hospital for fear of fentanyl exposure. You looked like the principal waiting on the other kid to come in. That's fantastic. I love that. I love when I get all the comments on, like, the most common one I get is like some sort of like, you are like a really dad kind of guy. You make dad videos. That's my favorite one. And my kids agree with that. And then the other one, my favorite, and somebody mentioned it in my live last night, that I look like Walter White. I still have it on my agenda to do some sort of video where I insert myself into a Breaking Bad scene as Walter White. I think that would be hilarious. So I've never gone live. I don't think I've gone live right in the middle of the day, so I have no idea how many people are around and are available to do that sort of thing, but figured why not. I meant to go live a lot earlier, but I got caught up with a lot of stuff. Last night's live was a lot of fun. Man, that was lively and popping for longer than I could even keep up with it. I would pay good money for that. For the Breaking Bad, I'll have to, when I get off this live, maybe I'll look into that. I actually don't know where people, like, how you incorporate, like, movie clips into your TikTok. People seem to do that easily and seamlessly, and I really don't know how you do that. Any great book recommendations for greater learning? I would get the critical care textbook. Hold on one second. Get this textbook, Critical Care Transport. That's a fantastic book to take you to the next level. You'll have to edit it off the app. Yeah, but I don't know how you do that. You know who keeps doing that to me is Charlie Swearingen. He keeps wishing me have a quiet shift. Also, if you are someone who is either a critical care provider or you have ventilators on your truck, this is probably the best ventilator guide that you can get. Ventilator Management by Eric Bauer. Eric Bauer is one of the founders of Flightbridge Ed, and that is just the Bible of ventilators. And then if you want to take it to the next level after that, Ventilator Management, Advanced Concepts in Critical Care. That's co-authored by Eric Bauer and Tyler Christofoli with FoamFrat. Well, I mean, the question was greater learning, but you should definitely learn what your roots are. So yes, American Sirens by Kevin Hazard is a fantastic book. I also, if you are looking more for kind of slice of EMS life or, deep dives on subjects, I also recommend Killing Season, and I'm going to look up real quick who the author of that is. I think it's called Killing Season. Yeah. Killing Season by Peter Canning. Killing Season by Peter Canning. And that is about a paramedic that served in Hartford, Connecticut, which was like ground zero for the opiate wars and the addiction issues coming from, is it hydrocodone? The one where the drug company was just like peddling it so hard that they basically got everyone in America addicted. This guy, this paramedic, he's the best of us. And the compassion that he showed that population and the way that he just inserted himself into people's lives and just gave them some kindness and some sympathy. And it's just incredible. Such an inspiring story. Y'all can clown, but I am already a black cloud. You can't curse me further. I mean, yeah, when people say that to me, I don't really care because we run one call after another. We don't really have any downtime, so wishing me a quiet shift, I hope I do have a quiet shift. You can't make me any busier than we are. And for a while, when we were getting our butts kicked, we were backing up at the hospitals for hours. And so being at the hospital was like the new post. You'd go to the hospital and you guaranteed 2 to 3 hours of downtime. But they've really upgraded their systems now, and they more or less get us in and out. So we're a lot more busier even than we used to be. Second week in medic school, any pointers? Yes. You need to get ahead on your reading, and you need to memorize your medications. Your medications, it's like trying to walk through a field of thorns, and all those thorns and vines start like attaching themselves to you, and eventually become such a slog that you can't make any forward progress. That's what it's like when you don't know your medications in paramedic school. So the cognitive offload to knocking out, memorizing those medications is going to benefit you to orders of magnitude. And then just stay ahead on your reading. Make sure you've read the chapter twice before you go over that chapter in school. And then immediately following going over that chapter, read it one more time and break up the reading with highlighters. And you're going to thank me for that. I'd rather run 6 calls than sit at the hospital holding the wall for 2 hours. Yeah, me too, but I did get a lot of reading done. I had my best year for reading this year because of all that hospital wall time. Can you explain how nitroglycerin helps pulmonary edema? Well, the pathophysiology of pulmonary edema is that you have so much fluid backing up into the capillaries from the heart failing as a forward pump that fluid starts to cross over the capillary wall, and it gets into the alveoli where it washes out the surfactant, causes alveolar collapse, and essentially that patient drowns. Not just from the fluid being in there, but also because of no perfusion happening because you've lost the buoyancy in your alveoli. Nitroglycerin is a vasodilator. The nitro from nitroglycerin is referencing nitrogen, and one of the mechanisms that is utilized by your body to cause vasodilation is nitric oxide that exists within your vessels. And nitric oxide causes vasodilation. So nitroglycerin, nitro, interacts with interacts with nitric oxide and causes vasodilation. And so when you open up that container, that fluid is drawn back into that container rather than residing in the alveoli. But you have to approach that from 2 places. You have to have the vasodilation, but you also have to have positive pressure within the alveoli so you can push that fluid back into the capillaries. I suffered a back injury. I'm going to need surgery and leave EMS. Well, I'm sorry to hear that, man. Sudden exit, an undesired exit in any field is just tragic, man. I'm sorry for you. Any medical jobs worth looking into besides nursing? Perfusionist, yeah, there you go. PA school, yeah. Respiratory therapy, I don't know what the upward mobility is in respiratory therapy. I imagine there's not much. But, nursing is a very you're not just limited to what a lot of people don't realize the opportunities that are in nursing. You can do flight. There are more nurses getting onto ambulances. There's all sorts of specialty provider situations that nurses, can serve in. So, I don't know why nursing would be unattractive to you at this point, but I would definitely consider nursing, because nurses, out of any other medical profession outside of physicians, have some of the greatest upward mobility potential. There's just always opportunities for nurses to increase their earning potential without necessarily giving up becoming a provider. Anyone have any experience with cardiovascular technologists? I certainly don't. Oh, there's Advocate Maggie. Hey, if you guys aren't following Advocate Maggie on TikTok, especially if you're a nurse, but support her anyway if you're a paramedic, please follow Advocates for Nurses. Advocates, the number 4 nurses. Please follow her. She is so passionate about advocating for nurses, and she deserves so much support. So please follow Advocates for Nurses. Advocates, the number 4 nurses. Some comments in this live were filtered to protect the community. Well, I feel so much safer. Love you too, Maggie. I don't want to do that right now, but sometime we should schedule going live together and just talk about the relationships between nurses and paramedics, sort of the relationship between nurses and EMS. I would love to do that. And what some of the lessons that EMS can learn from nurses, because nurses are much more organized in the way they advocate for themselves and, band up. EMS is much worse at that. Can we filter the rude patients then for our safety, right? Thoughts on the combi tube? Yeah, throw the combi tube in the trash. Combi tube is just garbage. It's a garbage airway. And I can't imagine why anyone would carry a combi tube right now instead of either an LMA, a King, or an iGel. God, the combi tube. How do we get better mental health support for EMS? Had a 7-minute-old peds arrest last night. Man. That's been a topic that I've been going over for the last 24 hours. I've been trying to advocate for increased pay, compensation, and mental health benefits for paramedics and, for firefighters and law enforcement as well, who are, tragically underpaid. And who are the biggest obstacles to that? Paramedics and firefighters and law enforcement who will die on the hill of this being a calling. Therefore, for some reason, it's such a noble endeavor that we don't deserve any of this compensation or mental health benefits. Get those obstacles out of the way and we'll do just fine. But I don't know how we can advocate for ourselves if we literally have EMTs and paramedics and firefighters saying we don't deserve this compensation. That, to me, the cognitive dissonance there is astounding. Also, divorcing EMS from the fire department will help with that as well. But if EMS unionized, our companies couldn't afford things like expired alcohol swabs, right? Grady just tried to unionize, and I think it was voted down, which is really, really sad. The Code Green campaign. Yeah, Code Green is fantastic. Also, the Wounded Medic Foundation also is an up-and-coming organization founded by the founder of IAMed. But, this is emblematic of the problem that we have in EMS. The only way we can get help is with bootstrapped volunteer organizations like Code Green Campaign and the Wounded Medic Foundation. What we need is for the public to advocate for us. What I have found is that when you appeal to the public, that's when you get results, because then you start doing end runs around the people who are obstacles within the field. It's kind of in what I equate that an example of that is when you work cardiac arrests on scene, you have higher resuscitation rates. And so when you appeal directly to the community and you point out things like the Damar Hamlin arrest, where the evidence was right there in front of a national TV audience, that working arrests on scene provides results. And even to a degree, the Lisa Marie Presley arrest, because she was worked on scene and they did achieve ROSC. Now, her etiology wasn't, conducive towards survival, but they probably wouldn't have ROSC if they had transported. And the same thing with our conditions and our mental health. You have to appeal to the public and say, I don't know if you guys know this, but 1/3 of EMS personnel at one point in any given year will have a suicidal ideation. That means that if 3 of you are in a room, 3 of you and then one really, really tiny paramedic are in a room, one of you that year is going to think about killing themselves. And almost 16% of firefighters in 1 year will actually attempt suicide. Tell the public that, and tell them that some of us make less than a fast food worker at Wendy's. And that's when you start getting action, is when you do those end runs around the people who are holding all of that back. Happy Friday to you, sir. I have nothing against the fire department, but if I wanted to be a firefighter, I would have gone to the academy. Sure. EMS also needs to be divided between interfacility and rescue. Units shouldn't be doing both. It's okay about turning the chat dark and gloomy. I mean, we need to be talking about these things. And we all need to be advocates for each other. As far as dividing units, I mean, it's really easy to say that units should only be doing 911, or they should only be doing critical care, or they should only be doing interfacility. It's much, much more difficult to make that a reality. And I'm not sure that's a practical or pragmatic approach. That's not to say that I'm not empathetic. Private ambulance companies do interfacility transportation. Well, I mean, so do public or hospital-based. They do that as well. A county service that I work for had their own NET division. A hospital-based system here in Atlanta does interfacility transports, and private services also run 911. So, I mean, I think that falls apart under scrutiny. Some areas are pushing firefighters to be medics. I mean, well, you're kind of late to the dance on that. I mean, most fire departments like to push, if they do fire and EMS, like to push their firefighters to become paramedics. There's lots of public doing them now because privates can't keep up. I mean, it's impossible to keep up. A local service here actually had to give up transport, had to give up contracts because of that. And, that's again, something that shines a light on how broken the healthcare system is. Not only can we not keep up in 911, but we can't keep up in interfacility. But, hospitals can correct that problem too by not sending patients by ambulance that don't need to go by ambulance. I've had plenty of ambulatory patients that have been take-homes. And maybe they're not ambulatory, but they can stand up from a stretcher and sit down in a wheelchair, and sit up from a wheelchair and sit down in a car. I'm not sure why all of these people are going back by ambulance. The entire healthcare system is a mess, and trying to spread limited resources over more area creates problems. Yeah, the entire healthcare system is crashing down on itself. And, there's going to have to be some sort of relief soon, some sort of comprehensive healthcare reform. And people are going to say, well, I want to keep government out of healthcare. You cannot reform it out of government. I mean, we are where we are because people who want to make money by way of the healthcare system broke it during COVID. So if you're telling me that capitalism is going to fix healthcare, then you get your news from Facebook, or you simply aren't paying attention to what's going on. You have no concept of history, nothing. And this isn't a political statement. It has nothing to do with whether you've veered to the left or veered to the right or kind of center based. It has nothing to do with that. It's just you have to be aware of how we got here. And so if you don't think that the only thing that can somehow get in the way of this is government, then you have your head in the sand. Because the commie tube is just ineffective. It relies on really, really imprecise placement of those tubes, and it's just terrible. It's just a terrible thing. And it's not even that the commie tube is ineffective. It's just that the SGA and the King and the iGel are so much more effective and in much more precise locations. It was broken before COVID. Oh, well, certainly. I'm certainly not saying it was in a perfect place before COVID, but it received, a bullet to the head during COVID. During the COVID pandemic, all EMS first responders were needed due to high demand in patient transport. Yeah. And not only was there that high demand, but right at the beginning of COVID, when things were kind of slow, that's when the hospitals got rid of all their part-time people. And the system has never recovered from that, because the people who are bean counters and stand to make money and get bonuses from the way hospitals function like it like this. They're doing more with less now, and they don't want to change that. The left hand doesn't understand how the right hand works. We need to break away from the Department of Transportation. Yes, oh, absolutely. We need to be out from under that and be under Health and Human Services. Commie tube also caused a lot of pressure-related injuries in patients. Yes. So do you think that an EMS pathway to clinical providers, in-hospital and out-of-providers, would help improve the retention of providers in healthcare if they leave EMS? Well, I don't think there's any one thing that can help retain providers. There's a lot of people that say, just pay us more. But, money is not a panacea. Now, when I say that, that doesn't mean that you should not pay us more. You should. But, this year I suffered a back injury from lifting someone on a stretcher, where somebody who I was working with didn't quite, they just didn't have the muscle memory to work with the lever on the stretcher, and they went too far down. And back injuries are a huge, huge thing in EMS. And, a lot of companies have policies that require all patients to be on a stretcher. Our service was never designed to operate like that. We were supposed to lift only in situations where a patient couldn't assist in their own lifting. And now, for liability purposes, my back is a natural resource. And that shouldn't be the way it is. A natural resource that is, if it's depleted, it's replenished with a new back. And there are hundreds of examples of like that where conditions have to be improved as well. If you gave everyone a 10% raise now, we would still be in the position that we are a year from now. It wouldn't solve any problems. It might help. It will help people pay bills, but it's not going to help them want to stay in EMS. So there's a lot of problems that need to be resolved. Creating the role of a paramedic practitioner is one of them, is one way you can help. Pay is a temporary fix. Have to fix the toxic work environments too. Yeah, and increasing education helps a little bit with the toxic work environments. And I'm not saying it helps 25% or 50% or 70%, but, when you have people that are out there getting degrees, they're required to learn the humanities. And so that could be history, languages, music, arts, liberal arts, that sort of thing. And that helps people with abstract thinking. It develops empathy. It develops diplomacy skills. And that helps tremendously with a toxic environment. It doesn't make it go away. you go into plenty of nursing units and they all have degrees, and they're, I get reports of how terrible they are to each other. What's up, Florida paramedic here. I still love my job, but the ER wait times make it unbearable. Yeah. Our service is now getting power stretchers because somebody mentioned back again. I am so excited about that because I feel like I'm getting a new lease on life. I was actually starting to wonder how long my back was going to allow me to do this. And I'm so thrilled that that's going to be the case. There's Mike Verkes. How you doing, man? Mike Verkes is with the EMS Show podcast. If you guys haven't subscribed to the EMS Show on your favorite podcast platform and haven't given it 5 stars, you need to go over there and do that right now. Go to Spotify right now and look up the EMS Show or whatever platform you're on and subscribe and give it 5 stars. Our county loses $2 million a year on EMS. And Medicare and Medicaid need to step up in that as well. I mean, there's a certain cost to what we do, and then Medicare and Medicaid are like, well, we'll pay this much. Like, what? Attrition from injury is solvable, but that would mean equipment and safety improvements. Right. What whiskey? A little early. I'm drinking cream soda. Paramedicine could help eliminate unnecessary transports, which helps the hospital. Yeah, and we're starting to get more of a deep dive into kind of, instead of paramedicine being the gateway to the hospital, paramedicine being more of a bottleneck. Well, not a bottleneck, but more of a filter to see who needs to go to the hospital. And I think when we start looking at it like that because the public sees us right now is not necessarily only being there for emergencies, but being there as being a first-line medical contact for any health abnormality. I think if you want to build on that, then what we should be, instead of being the pathway to the hospital, we should be a filter. And we get people to the appropriate location. So that involves having the ability to confer with medical direction and say you don't need to go to the hospital, or being able to reroute them to a different location, to be able to treat and release, that sort of thing. I saw your post on that today, Mike. Oregon has the legislation in the works to remove the degree program. That'll help. I mean, they're going to be right back where they started. I mean, why can't they just have smarter deployment of paramedics? Why can't they just do that? And have some legislation that says that, paramedics, if they're that smart, if they have degrees, that they should have the ability to be able to say, look, you can go to an urgent care, or at least with a quick FaceTime with a doctor, say, you don't need to go to the hospital. We're going to have you go to an urgent care, something like that. I dealt with a lot of BS as a guy and paramedic going through nursing school. Finishing up my degree, medic to LPC, would love to chat sometime. You can reach me on Instagram. Anyone can message me on Instagram. Someone asked me today, how much do you think EMS should be paid? My response was, there's no amount of money. It's a good question. I mean, you should be paid whatever the living wage is in the area that you live. If EMS shouldn't be something that's viewed as, a very temporary stop on the way to something else, because it's a profession for many, many people. And so you should be paid a living wage. I mean, King County pays somewhere between 900 and 100,000 for the medics, 90 and 100,000 for some of the medics that they hire. But of course, the cost of living is massive in that area. But a lot of services are starting to really, really up their game, and they're showing everyone else that you can pay EMS personnel a living wage. Oh my God, I haven't had cream soda in ages. I like it because It is essentially just cream soda flavored water. There is nothing artificial in it, and there's no sugar in it. But I don't like water, but I want to stay hydrated. So, and I really like the carbonation. So I drink, crap like that. Community-based EMS programs have a lot of effect in reducing strain on systems. Absolutely, absolutely. Maybe they should do certified for non-degree, licensed for degree, pay them accordingly. There was over 300 medics in Kentucky that did not renew their cert this 2-year term. A little over 2,000 did. Well, in 2022, 1/3 of our people left the workforce of their own volition. That does not count the people that were terminated. Those are the people that just said, I've had enough for whatever reason, either because they were, their upward mobility was taking them out of the field, or they just didn't like the conditions or what have you. But we lost 1/3 of the workforce. And we certainly didn't add that much back in. We've just implemented Tele 911 into our system. Most of the time it works well. It really does. We get about $35 to $40 an hour for EMT. Wow, that's amazing. Where are you? Everybody go apply there. Urgent cares can't even do what they are supposed to do now, let alone EMS bringing them patients. Well, that's a problem for urgent care to fix, which really is, again, part of a process of a complete overhaul of the healthcare system. But urgent cares exist to treat a certain category of patients, and the hospital should not be the solution to urgent care overflow. Opinions on paramedic pay? I mean, we've been talking about that this whole time, and my videos over the last couple days have reflected heavily on the need for increased paramedic pay. I mean, no paramedic should be making less than $30 an hour, period. EMTs, starting out probably 20. That's just a number that I threw out off the top of my head. Don't at me. Yeah, I'm not getting on you, but yeah, I mean, it's a big deal. Paramedics aren't paid enough. I left the road in 2020 to advance my career, let my license lapse too. No going back to the road. Yeah, you got to do what's best for you, man. King versus iGel. I prefer the iGel. I think that it's, out of the three that are used commonly, the LMA and the iGel and the King, I think that it's one of the better supraglottic airways. But what I also like with the iGel, and I wouldn't do this except in a very extreme circumstances, but it's something they can do in the hospital when they need to pull the iGel, because obviously someone who has an advanced airway is eventually going to need an endotracheal tube placed, is that you can put a bougie through the iGel, then pull the iGel and put a tube over that bougie. Speaking of airway and ventilation, I don't think I've heard you weigh in on CPAP versus BiPap. Well, I don't look at it as CPAP versus BiPap. I just look at what we can do in the field. It's degrees of therapy. So CPAP is incredibly beneficial to people that need to have Henry's Law put into full effect in the alveoli. Henry's Law is that the ability of a gas to pass into a liquid is directly related to the partial pressure of that gas over the liquid. And so when you increase the partial pressure of that gas over a liquid, it has a much greater ability to pass into that liquid. And so when we apply CPAP, we are maximizing Henry's Law because we're significantly increasing the partial pressure of oxygen in the alveoli. And a lot of patients feel like they're suffocating, and so long-term, BiPAP is better. Or, BiPAP is better all around. There's no argument there. BiPAP would be preferred over CPAP because you have different pressures when you inhale and exhale. Oop, I went blue screen for a second. inhale and exhale. But in order to have BiPAP, which, by the way, BiPAP is a trade name. It's actually bi-level is what you should be calling it. BiPAP refers to a specific trade name. But you need a ventilator or a special piece of equipment to do bi-level. And so, CPAP is just more convenient in the field. If you happen to carry a ventilator on the truck, then you should be doing BiPAP. But once they get into the clinical environment, they'll be put on BiPAP. And a lot of patients don't do well on CPAP because they don't have that bi-level, and so they just feel like that they're suffocating. Job just shorted me 32 hours of overtime and 16 hours of regular pay, getting tired of private EMS. I don't understand how I would just exist right now knowing that I was shorted. I mean, that's a problem that would get resolved one way or the other. Thoughts on PEEP valves? My department just ordered them. I mean, we should be using PEEP valves. I mean, why are we sacrificing alveolar recruitment? I mean, we need PEEP valves to retain that alveolar recruitment. Getting PHRN to volunteer in my rural outside. Getting your pre-hospital RN to volunteer in your rural outside, and severe shortage of EMS there. Yeah, that's awesome. I hope you follow Jenna Roxbury, because that's what she does. And it's really, really cool keeping up with her and what her experiences are as a RN on an ambulance. We as AMTs can use a vent to do CPAP. Well, that's really cool. I'm really glad that you get to do that. I wish you could be able to do BiPAP. But still, that's a win, and I really, really support that. That is very, very cool. At this point, there's just almost no one who can't benefit from CPAP when they're having respiratory issues. Increasing that positive pressure in the alveoli is so, so beneficial. I mean, and I am not recommending this as practice, but there's some talk right now about how asthmatics can benefit from CPAP, even though that seems counterintuitive, because they're trapping air. But there is some talk of how CPAP can be beneficial in that regard too. But don't go out and do that. Just go out and read some stuff, that's all. I read in the news they are getting school students to cover healthcare hospital shortages. That's interesting. I have seen where they're starting to incorporate students being able to get their EMT while they're in high school. How is this even possible? I'm not sure what you're referring to because I'm getting behind on some comments. You got my attention. Whiskey of choice. Everyday, special occasion. So a good everyday, well, it depends, because there's a couple, not all whiskeys are equal. So there's like Kentucky whiskey, which is your Jack Daniels or your Tennessee whiskeys. Well, your Kentucky whiskeys like Jack Daniels, that sort of thing. Then there's your ryes, and then there's, bourbon, and then there's scotch. Knob Creek and Bullet both make great go-to whiskeys, whether you like just straight up whiskey or bourbon, or whether you like rye and that sort of thing. So Knob Creek Rye and Bullet Rye are great everyday whiskeys. Now when you're starting to get into like good ryes, my favorite is Whistle Pig. Whistle Pig 10-year or 15-year at a minimum. For scotches, a good everyday one is Monkey Shoulder. It tastes like a high-quality single malt, but it's affordable. But now if you're talking about getting up there, Lagavulin, Ardbeg, those are great scotches. Highland, those are all great scotches. Bourbons is not really one of my favorite things to drink as far as whiskey goes. It's a little bit too sweet to me. But Eagle Rare and Buffalo Trace are great. Obviously, if you can get a bottle of Pappy, or Blanton's, you're doing really well. And I do not like Irish whiskey, and I just consider it to be party whiskey. We are pursuing the medical control board for us to do a bi-level. That's great. Severe respiratory protocol for us across the board with CPAP, with inline duoneb. Opened up everything. There you go. Excellent. I hope you're not doing duoneb in CHF. School students cover hospital positions, not as students, just helping. I don't know, cleaning. That's like, it feels like child labor. Horse Soldier bourbon is awesome. I think you recommended that last night. I don't remember if I've seen that or not. I had that I had that argument, and we were. The excuse being the CPAP prevented flash edema. Well, I mean, in CHF crisis or fluid overload, you've already experienced the flash edema. So that makes no sense whatsoever. I mean, the biggest reason why you shouldn't give a duoneb in CHF is it's just not indicated. Now, if someone is experiencing pulmonary edema and bronchoconstriction, that's one thing, and you can verify that very easily. These patients should definitely be on N-tidal already, and you can tell if they're bronchoconstricted by looking at their waveform and listening to their lung sounds. And, for the most part, you can start with the assumption in pulmonary edema that they're not bronchoconstricted. Wheezing and bronchoconstriction would actually be a rare presentation. Well, not necessarily, not ultra rare, but it's not a very common presentation in pulmonary edema. So you shouldn't even be considering it unless you're actually being prompted by waveform and lung sounds, and especially not Atrovent. Albuterol, some people give it out like candy in CHF, and there's really no evidence that it's harming patients in CHF, but you have to decide as a provider, and everyone listen to me here, okay? You have to decide as a provider whether you want to be a skills monkey or you want to be a clinician. And if for a skills monkey, you're just going to give everything to everything. And you're just going to look at the protocols as a cookbook, and you're just going to go down and give everything. If you're a clinician, you're going to do a capable assessment and a quality assessment of your patient and provide only what's indicated. Supervisor of mine says if you were going to use non-rebreather, use CPAP. I don't know if I necessarily would want to argue anyone away from that logic, but I think that would fall apart under scrutiny. Let's talk about COVID. One of the problems that people who had COVID were experiencing is a term that we call happy hypoxia, in that they had absolutely no evidence of respiratory distress. They were pink. They were breathing only, 16, 18 times a minute. Their lung sounds were almost unremarkable, maybe the slightest adventitious lung sounds. They had no outward indicators of respiratory distress, no accessory muscle usage, no tachypnea, but they were satting 68%. And I'm not sure if that person necessarily needs to be put on CPAP rather than waiting so they can get put on bi-level. And, a non-rebreather would probably be a good option there, or even just flush rate oxygen, nasal cannula at 10 liters, or a non-rebreather at 30 liters. I don't know if they necessarily need to be trapped in a CPAP mask in that situation. Can you explain or do a video sometime on CHF versus COPD? Used to confuse me when I was a new medic. There is a video pinned right now on my TikTok on the flow to versus flow through problem, but I'll quickly go through it. COPD is primarily what we call a flow 2 problem. You have narrowed and inflamed airways that's preventing gas from getting down to the alveoli where it can transfer into the capillaries. That's a flow 2 problem. Gas is not getting where it needs to go. Then you have a flow through problem. That's more of a CHF problem, where the alveoli themselves are collapsed because the pulmonary edema has caused fluid to get into the capillaries, wash out the surfactant, and now we have alveolar collapse, so there can be no gas exchange. That's a flow through problem. Okay? So with COPD, you want to correct the flow 2 problem by administering a bronchodilator, something that's going to open that narrowed airway and inflamed airway back up so that gas can get down to the alveoli. In a flow through problem, you want to get positive pressure down to those alveoli, and you want to have vasodilation. So you want to open up those alveoli again so gas can get through to the capillaries, but you want to open those capillaries up as well so they can reabsorb fluid and allow gas to get into them. Now, with COPD patients, we're more and more realizing that by getting some positive pressure, we can correct some of those problems that are existing with those alveoli, where either because of the destruction of the alveoli with like emphysema, or the destruction of the alveoli with bronchi buildup, we have what's called those blebs. By getting that positive pressure, we can open that back up a little bit and cause better exchange. But just ask yourself on every one of these calls, is this a flow 2 problem or a flow through problem? And differentiating them is essentially down to lung sounds and capnography. Somebody with CHF is going to have relatively normal waveforms. Somebody in COPD is going to have that shark fin or something resembling shark fin that tells you that you have those narrowed airways. And if you have a normal waveform, that means that that person does not have bronchoconstriction, period. But you also listen to those sounds. If you hear a whistling sound, that's evident of the fact that they have narrowed airways. It's like any instrument. When you put pressure against it, if you narrow the tube, it creates a sound. That's literally how, brass and wind instruments work, is by reducing the air, reducing the width or diameter of a tube so that there's a sound created. And so that wheezing is indicative of narrowed airways, and so you just treat accordingly then. I hope that helps. You feel free to ask more questions. CPAP scare people. Yeah, BiPap is much easier on a patient. They just don't feel like that they're breathing from a fire hose on BiPap. I still get to check out your page. Jenna recommended me to your page and saw you live. That's cool. I like the way you explain things. Thank you very much. Someone say whiskey? Not right now, brother. Anyone else feel like our symptoms or pain is pushed aside by ourselves and or others? Well, absolutely. Our own pain or mental anguish as providers is diminished, and we as providers often diminish other people's pain. Why not treat hypertensive crisis with nitro in the pre-hospital setting? Because all hypertensive crises are not created equal. And you really need to know what you're treating. Nitro also metabolizes relatively quickly, so there are better ways to treat hypertensive crisis. Labetalol would be a better route, I think. And we're starting now to move away from we don't treat hypertension in the field because it's really a non-compassionate approach. Passive oxygenation in cardiac arrest. So I think it's a good strategy. So if you're not familiar, passive oxygenation or apneic oxygenation in cardiac arrest is where in the first few minutes of the code, rather than providing mechanical ventilations with a bag valve mask, you place the patient on flush rate oxygen. So at the very least, a nasal cannula at 10 liters, preferably a nasal cannula at 10 liters, a non-rebreather at 25 liters, which is about as much as a normal flow meter will allow in a portable oxygen tank, although you're going to tap that very, very quickly. And for the first few minutes of the code, you just rely on passive oxygen intake from your recoil during compressions. And you can get a person up to 100% that way. And what that does is allows you to focus on quality compressions without competing intrathoracic pressure from that bag valve mask. Now, there have been studies that have evaluated continuous compressions in providers where there's not an advanced airway placed. And so they're doing continuous compressions with various apneic oxygenation strategies and comparing that to 30-2. And this is the result here. 30-2 actually has higher survival rates. The caveat to this is that most people are really bad at 30-2 compressions. And so think about all the cardiac arrests you've been on. A lot of times the person who's on the bag is the least skilled person in the room. Not necessarily because they're poorly skilled, they just may be new. That's often what we do with the newer people, is we put them on bagging. And ventilating a patient in cardiac arrest has one of the highest skill thresholds of anything we do in a cardiac arrest. You want to be bagging with these princess puffs where you have your pinky up in the air and you're just using 3 fingers to squeeze the end of the bag and getting 350 milliliters of air in on every compression and not overventilating, only 8 to 10 ventilations a minute. But you see providers double squeezing the bag and putting in 1,000 milliliters and bagging 15, 16, up to 20 times, up to 30 times a minute because they're so worked up. They're also leaning on the airway, and so that kind of contributes to dislodging the I-gel or whatever you have in there. And so quite often 30-2 is not performed very well. And so in that situation, continuous compressions would outperform 30-2. But if you can perfect your 30-2, you're probably doing better than apneic oxygenation. Yeah, we don't want to rapidly lower anybody's blood pressure ever, with one exception, and that's SCAPE. So if you're not familiar with what SCAPE is, SCAPE means sympathetic crashing acute pulmonary edema, and you've seen that time and time again. It's what we often call CHF crisis or flash pulmonary edema or acute pulmonary edema. It's not these patients that over a week have had gradual fluid buildup and they have peripheral edema and JVD and wet lung sounds. It's these people that were doing one thing one moment and suddenly, are full of fluid. And those are the patients that you can hear their fluid when you walk in the room. They may have a little bit of pink frothy sputum. Their blood pressure is like 200 over 100. And what it is, it's a massive catecholamine response. And so you have a massive sympathetic crashing acute pulmonary edema, a massive sympathetic response that's driving up your blood pressure and causing massive peripheral vasoconstriction. And it's driving all your fluid to the core. And so that's why those patients are experiencing that pulmonary edema. And we do want to rapidly lower their blood pressure there by way of vasoconstriction. And so that's where push-dose nitroglycerin comes in, where you push something like 800 micrograms over a couple of minutes, or you give 2 milligrams every 2 minutes until you get their blood pressure lowered. And in that situation, that sounds like a lot of nitro, but they're not bottoming out. We're just normalizing their blood pressure with that. That's the only situation where we want to rapidly lower their blood pressure. And studies have shown that when we do that, not only are outcomes better, but avoidance of intubation improves. Agreed. We have told now not to use oxygen and just use compressions. Well, you should use oxygen. You should use oxygen. You want a little bit of help in getting it down there, but you don't want to necessarily ventilate. But, in Seattle, where they're all about what you would call min-maxing, which is like maximizing the effectiveness of every intervention that you're performing. If they have ALS on scene, they perfect 30-2. They don't do apneic oxygenation. But if they have BLS, they do what's called a BLS 10, which is they do continuous compressions, but every 10th compression, they just sneak a little breath in between compressions. The compressions don't pause for the ventilations. They just try to sneak it in there. Blowing them up like a balloon. That's right. Incorrect mechanical ventilation and cardiac arrest inflates the lungs more so than a healthy person would have inflated, and that prevents cardiac refilling. There's only so much pressure within the chest, and so a person who's alive, their natural processes within the body, there's actually this thing called the intrathoracic pump, where the lungs and heart actually work together to optimize cardiac refilling and cardiac output. But if a person's not alive, that homeostasis isn't there, and so you are able to overpower the heart with the power of your ventilations. Michigan requires 1,000 milliliters or less adult BVM, no more than 1,600 milliliters. That is killing people, my friend. No more than 350 milliliters a squeeze. You guys should switch to pediatric BVMs immediately. Evidence-based care and same rules everywhere seems like a good idea. Yes, absolutely. Is it just me, or has our profession lost the art of appointed assessment and thorough hands-on evaluation? Absolutely. People often approach these things as just totes. I've seen time and time again where a medic has no curiosity whatsoever and no inclination to do any more than the bare minimum, and it's sad to see. Help, albuterol with CHF and wheezing, yes or no? Well, again, ask yourself, do you have a flow-to problem, a flow-through problem, or both? CHF is a flow-to problem and a flow-through problem. Wheezing is indicative of a flow-to problem. You have a narrowed airway, and you want to correct that because that's inhibiting gas getting to the distal ends of the airways. So CHF with wheezing, yes, absolutely albuterol. And I think that there's a lot of people that try to logic this out and say we don't want to increase myocardial oxygen demand by giving a beta agonist, such as albuterol. Albuterol is supposed to be more beta-2 specific, but it definitely works on beta-1. There's about a 10% increase in heart rate there. But there's no evidence that outcomes are worse when we give albuterol. But again, that doesn't mean that you give it for everything. You give it when it's clinically indicated. So CHF with wheezing, yes, you would give an inline nebulizer with your CPAP. Thank you for your education on naloxone exposure. You are welcome. And I love getting deep down into the nitty-gritty on that and talking to people. And you know what? I've inserted myself into conversations on other discussions. I don't like to get overly political. So, there's some people that have channels where, talking about Narcan and police Narcan exposure is a very political issue for them and not one about science. So I kind of stay away from that. But I'll get involved in it, and I find that as long as I stay calm and rational, provide evidence and links that people, even if they don't agree with it, at the very least, they're open to thinking about it. $350 milliliters, that's why they reduce the size, because you can never get all the air out 30% of 1,000 milliliters. Most of the BVMs we have are 14 to 1,500 milliliters. So if you double squeeze that, you are definitely getting 1,000 milliliters. And I mean, the average tidal volume of a person who is at rest, 400 to 500 milliliters. So why would you give that? Why would you double that in cardiac arrest? That makes no sense. Narcan for altered mental status, not indicated. Narcan exists for one reason, and that's to restore ventilations to a person who has significantly depressed or absent ventilations as a result of opioid toxidrome. That's it. That is the only indication for Narcan. I will say that there is some talk right now about some early science, nothing that has a body of evidence behind it. In fact, everything about it All the science behind it is underpowered. But there's talk right now that administration of Narcan to someone in shock can actually help reverse a little bit of those shock symptoms by causing some peripheral vasoconstriction. But no one should be acting on yet. No one should be giving Narcan for general shock. It's just a little bit of theory crafting in the science community. Also thoughts about Narcan for arrest. So I'm not married to a point of view on that. There is some data that suggests that opiates are actually cardioprotective, meaning that while that patient is in arrest, that the opiates are actually preserving some of the function of the heart. And by giving Narcan, that you are actually reversing that and lessening chances of survival. But there are also people that say, well, it just makes sense from a pathophysiological standpoint. No one can actually explain that to me. They just say it. That's just something they say. So I'm eagerly awaiting for somebody to give me that pathophysiological breakdown. But also, here's my thought. It takes up very little bandwidth as far as approaching a cardiac arrest to give Narcan. There's no indication. There really is no body of evidence that we're harming patients by giving them Narcan. And particularly in a PEA arrest, I have seen time and time again where we have a patient where I'm being told that they're in PEA. And I see them give Narcan, and within a minute that patient is sitting up. It is highly unlikely that patient was actually in cardiac arrest. That patient was probably simply in a low flow state and just needed Narcan to wake up. And there's also a lot of data out there that shows that pre-hospital providers like EMTs and paramedics really suck at finding a pulse in a short amount of time. And so they get in there and they're like, after 10 seconds, I can't get the pulse. And so they start compressions. And in reality, the pulse was there. We just didn't have enough time to confirm it. So I'm a big fan of Narcan in PEA arrest, and I don't have a strong opinion outside of that. You don't EC grip with one hand 350 milliliters with other just looking for chest rise. I mean, this is obviously personnel dependent, but you shouldn't be EC gripping patients to provide mechanical ventilations, period. It should always be a two-man process with one person holding a mask seal and the other person squeezing the bag. It's crazy. I work in central Illinois. Oh, you work near that prison where there was all of those people. Yeah. So if you're not aware, a couple of days ago in a prison in Illinois, 22 of the guards were taken to the hospital because they experienced generalized symptoms like lightheadedness and nausea and dizziness because they responded to a prisoner who was experiencing some sort of medical issue. And either there was a substance on the patient, I think it was actually near the patient. And so they all went to the hospital. Well, the substance was baby powder, and the other thing was acetaminophen nasal spray, which doesn't cause any sort of symptoms like that. Fortunately, they were not given Narcan, so we didn't increase the madness even more. But if you're wondering about police exposure and cardiac arrest and why they're having these police exposure to fentanyl and having all these weird symptoms, look at this case right here. It's called the nocebo effect, where if you believe a substance can harm you, you can and may become symptomatic. But those symptoms that the guards have were consistent with what these police are reporting when they have these fentanyl exposures, and Narcan is not indicated there, just support, that's all. What's your opinion on diluting Narcan? Well, I think it's reasonable to put it in a drip. And you have the opportunity to do that because we should be oxygenating patients who are in respiratory arrest before reversing the respiratory arrest. And that's going to solve a lot of the problems that we see with patients coming out of it and having significant undesirable symptoms. You know, Narcan-induced pulmonary edema, which is very, very rare. and even some withdrawal symptoms. If you oxygenate your patient adequately, chances are that even if you wake them up completely, they'll be okay. So, but a Narcan drip is fine. Nebulized Narcan is fine. The only thing I don't advocate is intranasal Narcan. It's fine for people who are first responders who don't have the ability to do intramuscular Narcan. It's fine for the lay public. No one should be discouraged from giving intranasal Narcan when they don't have any other option. But if you're an ALS provider, you should not be doing intranasal Narcan. It's a very unstable delivery method, and patients come out of that feeling terrible. Intramuscular provides a much more stable delivery route. So, but yeah, diluting Narcan like in a drip is fine. Or are you talking about maybe diluting it in like a 10 or 20 milliliter syringe? As long as you're delivering it slowly, that's fine too. I recently had an EMS worker at a party who started compressions on a patient whose BP tanked, so the patient collapsed, and he claimed he brought him back with CPR. Unlikely, but more likely that person had some sort of vagal incident, and he performed the compressions, restored cerebral perfusion, in that low flow state from the vagal incident also reversed itself, and that person was fine. No one should expect somebody to have ROS simply from compressions. It's incredibly rare. But he did the right thing, absolutely did the right thing. So let him tell that story, because, we, in telecommunicator CPR, which is when dispatch gives dispatch instructions, the way it's most effective is when you use what's called the no-go strategy. Are they completely alert? If the answer is no, you go on to the next question. Are they breathing normally? If the answer is no, then you you go to compressions. No-go. And so that patient did the right thing. The patient was not alert and not breathing properly and needed compressions. So good for him, and just let him tell that story. Thoughts on antibiotics, like for open fractures or sepsis. I was talking a little bit this about last night. I don't see any reason why medics shouldn't be giving ANSEF, in the presence of, open injuries from trauma. If those patients, a point that was made last night was that if those patients are trying to go straight to the OR, that getting ANSEF on board pre-hospital is a pretty good strategy. Should Narcan be taken away from firefighter and police, give them a BVM instead? No, they should just give Narcan. It's okay if that patient doesn't feel well and they come out of it. It's okay if they're in withdrawals. It's okay if they have pulmonary edema. We can work on that too. I mean, these people aren't drowning and dying. They just need positive pressure. Like I said before, providing bag valve mask ventilations actually requires a lot of skill. And, in a cost-benefit analysis and, looking at skill thresholds and risk stratification, I think it's just better that first responders like, non-BLS firefighters and police, if they just give Narcan. There's this weird thing that ALS providers have, and we're developing a chip on our shoulder about first responder and lay Narcan delivery, and we need to get over that. This is saving lives. We're overthinking this. Intranasal for peds. It's preferred in my current system. Intranasal what? Questions. SVT with panic disorder. Can they both be present? Well, sure. You can have a pathology that predisposes you to SVT, such as Wolff-Parkinson-White syndrome, POTS, postural orthopedic sympathetic, whatever that stands for. There can be any number of conditions that somebody who suffers from panic disorder may have some increased sympathetic stimulation and then go into, SVT. But work the problem first, work on the patient's breathing. And, here's something, let me get on my soapbox right here. Telling a patient to just breathe is not helpful. And in some situations, it's just going to make the patient mad. God, that was a terrible sentence. In some situations, it's just going to make the patient mad. Telling them to breathe through the nose and out through the mouth, or whatever it is, breathe through the mouth and out through the nose, is not helpful. What the patients really need is some assistance in that breathing. And so the best thing that you can do is hold your breath with the patient. This is when you have ruled out other pathologies. So you can do some vagal maneuvers if you really, really are convinced that this isn't just hyperventilation syndrome. But do, vagal maneuvers. But this is what you can do in these situations where patients who suffer from panic and anxiety are now in hyperventilation syndrome. Just say, hey, this is what we're going to do. In about 30 seconds, we're going to hold our breath for 6 seconds, and I'm going to do it with you. And so when you get to that 30 seconds, just count them down. 1, 2, 3. Here we go. Hold your breath. 1001, 1002, 1003, 1004, 1005, 1006. And say it calmly. Okay, let's let it out. Okay, we're going to do that again in 1 minute. And just keep doing that. And you are providing an empathetic tool for those patients to break out of that hyperventilation cycle. That hyperventilation cycle is a positive feedback course. The worse it gets, the worse you feel, and the worse you feel, the worse it gets. But telling a patient, just breathe, just work on your breathing is so unhelpful and so unempathetic. How about chest compressions and trauma arrest? Chest compressions and trauma arrest often make the injuries that resulted in the arrest worse. Hypovolemia, you're just squeezing the blood out of the body. Some sort of compromised airway, you are getting no oxygenation, so you're not helping. Tension pneumothorax, you're worsening the tension pneumothorax and not helping with perfusion. Cardiac tamponade, you're worsening the tamponade and not causing any perfusion. And so it's not that you never do compressions, but you shouldn't lead with compressions. On that traumatic arrest, do other things that are more likely to be beneficial first. Bilateral needle decompression, bilateral finger thoracostomy, intubate or get a surgical airway, pericardiocentesis if you're allowed to do that, and volume replacement, preferably with whole blood. Get TXA on board. Get those things done and then think about compressions. Regarding antibiotics and EMS, wouldn't you need blood cultures though? No, because ANSEF is given prophylactically to prevent infection from those open wounds. It doesn't require cultures. Now, also there are services that give antibiotics in a sepsis protocol, and in that case, they just give a broad spectrum, a single dose of a broad spectrum antibiotic. But there's really no evidence that we're moving the dial on outcomes with sepsis with pre-hospital antibiotics. Oh, intranasal Narcan with peds? Yeah, intranasal Narcan. Oh, wait, did you say intranasal or nebulized? With a pediatric, let's say it's like a I wouldn't give intranasal Narcan to a ped, no. I would rather give them intramuscular. For Versed, I wouldn't want to give intranasal Versed if we're giving it for a seizure, because intramuscular has been demonstrated to be more effective at breaking that seizure sooner rather than intranasal. And the problem with any intranasal medication is that a lot of times when we give it, we don't have an intranasal preparation. We're just drawing it up and then squirting it out with an atomizer, and so those patients get a lot more fluid in each nair than they're really supposed to, and it drips out or it drips back and they swallow it. And then a lot of people also administer it improperly. A lot of people, I'm going to go sideways here, they want to go up with that atomizer, and you should actually really be going like this in order to get that where it needs to go. But with intranasal Narcan in particular, that can actually put that patient into withdrawal, because when it does work, they get a lot of it too soon. So with Versed, I would much rather do intramuscular. my friend works in a region where they have to call medical control to administer Narcan and cardiac arrest. I don't think that's called for. I mean, either put it in your protocol or make it paramedic discretion, but you shouldn't require the you shouldn't put the cognitive demand on someone who's working an arrest to make a phone call to ask permission for an intervention. So either say yes, no, or whatever, but don't make them call on the phone. I wish EMS advanced to make it worth staying in the field. Just went to see the ICU as a nurse. Yeah, I mean, working as an EMT and not moving up, there's going to be diminishing returns there on your earning potential. And it's POTS, yeah, okay. Postural orthopedic tachycardia syndrome. What am I thinking of? I was confusing it with, there's the syndrome that women have where they have kind of like the endometriosis-like symptoms. I can't think of it off the top of my head. Physical contact and coaching is effective. Smell the flowers, blow out the candles. I think you have to read the room when you're just kind of telling people something like that. There are some people that get very angry with platitudes. They know that they can't help themselves and they're looking for help. And if they could have smelled the flowers and blew out the candles on their own, they would have done it already. And so you may get that odd patient that you can just tell them to do something and it's helpful. And sometimes just you talking to them and them hearing you talk to them, you may not, with your instructions, not helping, but the sound of your voice may be helping. I'll acknowledge that. But generally speaking, I think that more patients probably feel patronized with that sort of talk. That's just my opinion. Any reason why a 14-gauge IV should be established? Not in my opinion. Blood flows just fine through an 18-gauge, especially when you have lure locks on and all sorts of lines. You're not really getting much benefit out of a 16, much less a 14. And, a lot of people want to flex with placing a 14, but 14s are really hard to place. If you're placing a 14, chances are these people have some cardiovascular compromise and their veins may not hold a 14. And I've seen plenty of people pockmark a patient with 14s and be unsuccessful when an 18 would have been just fine. Maybe you can convince me that there's some situations where rapid infusion of blood may call for a 16, but a 14, no. Any advice on anchoring veins? Seems as soon as I put pressure on some veins, they disappear. In that case, number one, when you put pressure on a vein, you see where my thumb is? I have to work over that thumb now to get that IV, and that's not very efficient. So instead of doing this, grab the hand like this, and then pull like this. That holds that vein still right there, and you have a clean runway to get that needle in there, and you're not working over your own thumb. And you can also put multiple tourniquets on a vein as well. A lot of people don't think about that, is that one tourniquet is good, 2 tourniquets can be better. Pelvic inflammatory disease. It's more comprehensive than that, I think. God, I feel bad because I have a really good friend that has it, and I can't think of what it is. POD something. Hemoptysis. Hemoptysis is not a huge issue with an 18 gauge, and it's not even a huge issue with a 20 gauge. I mean, if you're getting a liter of blood and, 25 milliliters of it results in hemoptysis, that's nothing. I'm a medic in the field. I do travel currently in Oakland, California. All right. I would love to work in California. I just don't know how anybody survives or provides for themselves on EMS wages, at least in Southern California. I don't know. I just don't know how you do that. $7 a gallon for gas. I mean, that's crazy. caught up a little bit here on questions. I'll probably hang out for another 10 minutes or so. Usually on Fridays, my content starts to tailor down a little bit because my girlfriend gets home from work on a Friday afternoon. She hasn't seen me in a couple of days because I've been at work. And so I want to maximize that time with her on a Friday evening and over that Saturday and Sunday. So, I kind of save the content I do on Saturday and Sunday with maybe just some quick off-the-cuff stuff. And then I kind of start building back my activity up on a Monday. You use racemic epinephrine. Not specifically racemic, because that's a specific preparation, but I do use nebulized epinephrine in some cases, and that's a completely legit strategy for respiratory difficulty. I think you should use nebulized epinephrine before you would consider intramuscular epinephrine. Resources for MedMath, your phone. No one should be doing MedMath on a call. You should have either an app or you should have some sort of reference card or badge buddy or something like that. I have no patience for the people that want to reinforce people doing MedMath on a scene. You have some sort of pediatric crashing in front of you. I don't want you doing math. If that's my son or my grandson or my granddaughter, I don't want you doing math on scene. Please pull out Critical X or your badge buddy or whatever it is, and please go by that. Please, please, please. It's fine if you know it. It's fine that they teach it to you in school, but in the field, please, please don't. Please don't. And any advice for learning to run codes? I'm having trouble with the meds. Like memorizing them? I mean, you are giving them that whole amp of epi. So that shouldn't be a problem when you're doing it every 5 minutes. And with amio, you're giving them half of it first and then a whole one later. And then with lidocaine, I'm not sure why anybody's using lidocaine at this point, only because, again, why are we doing math on scene? But, I mean, if you're on your own learning to run codes, then something's wrong with your training. Every single organization should be repeatedly training their people on how to run a code. And I couldn't even begin to start right here in a live on how to run a code. But just know this, the only two things that are known to benefit patients in cardiac arrest as far as survival goes are quality compressions and timely defibrillation. So work on reducing pauses, work on making sure people are trying to get as close to 110 beats a minute as possible. Make sure that whoever is performing the compressions is open to being corrected during the compressions, because you'll start to get people who are doing perfect compressions, right? Perfect compressions, arms locked, they're coming completely off the chest. And after about a minute now, they're starting to lean on the chest, and they're not coming all the way up. And that is disastrous for a patient. And then make sure that you are pre-charging the monitor prior to the rhythm check. You push charge, and then at the rhythm check, it's hands off. If it's shockable, you shock. If it's not, you cancel the charge and you immediately keep going. You can reduce that to 2 to 3 seconds. But as far as running a code from front to back, there's just not enough time in the world right now to start here. So as far as a resource goes, I don't have one right off the top of my head. I really don't. There might be some good videos on YouTube to start with. I would look up any material that the Seattle Resuscitation Academy is putting out. Thoughts on EMS getting antibiotics in the field? Had continuing education, they talked about it. For the most part, we don't see any improvement in morbidity or mortality for sepsis protocols for EMS where they give antibiotics. But, ANSEF and trauma is probably fine. I used Duonab on a croup call and got flack for not using racemic first. Well, you should have, because croup is not an issue of bronchoconstriction. Croup is an issue with your upper airway, with a dry and narrowed upper airway. And racemic epi stimulates those beta cells up here, causing your airway to open up. So that's really where you should start there. And in reality, you could probably just nebulize saline for some of these patients and they'll do better. A lot of these patients do better when you take them out of the house. This is an anecdote that we have in EMS. You get this croup call for a pediatric. It's in the middle of winter. It's cold outside. People are running the heat in their house, which is very dry, and that child reacts and develops croup. You pick that patient up and you carry them out to the truck, and on the way out to the truck, where it's humid outside, and they suddenly sound much better. And, you know, it's really just about getting that moisture to that area. But, I mean, so you can nebulize some saline and see if that works. And outside of that, I'd probably start with racemic or nebulized epi. Albuterol or Adunab actually wouldn't be indicated in that situation. In medical school, we did drug-assisted intubation instead of RSI, talking about passive oxygenation. Yeah, there's a time and a place for drug-assisted intubation where you just sedate them and intubate them as opposed to paralyzing them, or sedating them and paralyzing them and intubating them. Question. Personal. SYA. I don't know what SYA is. And drug-assisted, average anyone in EMS, EMT, para. You're going to have to do better than that. I'm 54 years old, and I don't always keep up well with the fragmented way people communicate on the internet. Have you seen the Michigan My Medic cards? I have not. With my peds arrest last night, med control seemed to be annoyed I was asking them for med doses. Well, why were you? I mean, we have the hand-heavy hand system, and we have your Braslo tape, you know, so why aren't you relying on that? With the hand-heavy system, you should be walking in. If you can teach yourself the hand-heavy system, you can walk into a pediatric arrest knowing what all your doses are before ever having patient contact. Specifically D10 in my arrest. D10 should be 5 milliliters per kilogram from cradle to the grave. I always have to actively tell myself to fully recoil during CPR. Good to have someone watching. Yes, because we get tired and now we're relying on the chest rather than coming off the chest. Your hands should be coming your fingers should stay there, but your palms should be coming just off the chest when you recoil. And here's the thing. Failing to recoil, even by 20%, you might think, well, I came up 80%. That's pretty good. But that 20% compromise in recoil results in an average 40% decrease in perfusion to the heart and to the brain. 40%. Because remember, particularly when you're coming up, that's when you're perfusing the heart. When you push down, you're perfusing the brain. When you come up, you're perfusing the heart. So if you don't come up all the way, I mean, you're trying to achieve 15 millimeters of mercury of coronary perfusion pressure when you're doing chest compressions. That's really low as far as coronary perfusion pressure goes. That's the minimum that we want to hit, 15. And so if you're compromising that more by not coming up, that's a death sentence to the patient. And this is also why we swap compressors every 2 minutes. I don't care if you say, I'm good. Get the fuck off that chest. Sorry for my language. SYS. I don't know what SYS is either. Should a Lucas be used even if you have enough personnel on scene? Not if you're all trained in high-performance CPR. High-performance CPR outperforms the Lucas any day of the week. So if you've trained on those Laerdal mannequins with the feedback device where you see that you're leaning and you try to keep, you are shown an evaluation of your performance in CPR, and you're shown how to properly deliver a breath and work on your timing and that sort of thing, that's going to outperform CPR every time. And I should put a link in my bio of what perfect high-performance CPR looks like. But if you're a crew that's not really trained that way, and not, there's a lot of people in crews that are phoning it in. Let's admit that, I've seen plenty of providers lean over a patient with one hand and do CPR, or straddle a patient and lean at the waist and do CPR. I mean, you can't recoil all the way doing that. And those people are phoning it in. They just don't care to do a proper CPR. And to me, if I can't corral everyone to do great CPR, then I am going to start thinking about the Lucas. But if we're all committed to really high quality CPR, then I don't want to interrupt that process with the Lucas. Do you do another round of compressions once you have ROSC, or initiate post-ROSC care? Well, if you've established the presence of a pulse, then that's it. You don't keep going. But, if you've defibrillated somebody, you immediately start compressions right there. And so, if you successfully defibrillated them, then they're getting another 2 minutes of CPR. But once you get the pulse, that's it. I mean, where does that end? So once you've established the presence of a pulse, it's time to support them, because, compressions are traumatic, So compressions are indicated for pulseless patients. So if you have the presence of a pulse, it's time to start initiating post-ROSC care. And don't forget to take a beat before you transport that patient. It's called the 10-minute cool down. Of course, follow your local protocols. But the 10-minute protocol allows you to get some things done, to start providing some support for your patient, to get 12 leads, to package them properly, that sort of thing. And it ensures that you're not going to lose that pulse when you're trying to get that patient out of the house, which is when you're most likely to lose that pulse after ROSC, is in that time when you're getting that patient out of the house. And so, those are times where quite often we can't monitor them. We have to disconnect the monitor because if we have a narrow hallway or something like that, or we're on stairs, or you just can't fit all those people. And so you can go 2-3 minutes between getting that patient off the floor and getting them in the back of the truck before you plug the monitor in. And here we are, that patient, that whole 3 minutes was in VFib. And, that's a death sentence to the patient. So we want to make sure that that pulse is not an epi-pulse. And so get some things done before you move that patient. Thoughts on documenting the pleth wave during compressions? That is such a great question. You should be monitoring your pleth wave during cardiac arrest. It is a really great indicator of the quality of your compressions, because the only thing that pleth wave is measuring is whether or not it's picking hemoglobin up on that pulsatile blood flow. And so if you have a flat line on your pleth wave, your compressions may not be adequate. Now, I don't recommend you screwing around with your compressions because of the pleth wave. But if you have a decent pleth wave during compressions, it's definitely confirmation that you're doing good compressions. And if you happen to notice when you do your rhythm check that you have a pulsatile pleth wave, that may be one of the first indications to you, even outside of end tidal, because sometimes you can actually have really decent high end tidal during an arrest. If you do a rhythm check and you have a pulsatile pleth wave, you should definitely be checking a pulse. But yes, document that pleth wave. Man, great comment, man. Thank you. I tried to send you a message. You can send me a message on Instagram. I can receive messages on Instagram, EMS Avenger. But I want to say thanks for being a big inspiration, striving to always be a better provider. And I like to think a lot of it is because of what I learned from you, my friend. Man, that just makes me feel so warm and fuzzy. Thank you so much for that feedback. They teach us in medic that once you have ROSC, the heart is still weak, hence do another round. Well, I don't think that is taught by ACLS or the Seattle Resuscitation Academy. I'm going to have to look at that, but I don't think that is evidence-based. Don't go by what I'm saying right now, though. I'm going to pull up a link to search for that. And I will get back to that later. But if you have the presence of a pulse, now it's time to provide that patient some support. You're going over tracheostomy. We'll have fun there. I did one surgical airway in my time. Oh, I see what you're saying. Systolic and diastolic. Systolic and diastolic blood pressure and I don't know how I missed that. I guess because I saw those initials thrown in right when somebody was talking about drug-assisted intubation and RSI, so I associated that with some sort of airway thing, and I wasn't following. But, we're deep into this, and I'm so sorry. I'm so sorry to ask you this, but can you ask the question again, what you're referring to related to the systolic and diastolic blood pressure? I'm so sorry. These questions pile up, and so I lose the reference for some of these questions. I can't get many people to realize the pleth wave trick. Everyone thinks I'm crazy. Maybe I'll do a video about that. Pleth wave also helps confirm capture and pacing. Yes, it does. Systolic and diastolic blood pressure and what's the average for us first responders? In what context? Use of adenosine and AFib with RVR. You should not be using adenosine and AFib. Adenosine is not indicated in AFib. It doesn't convert AFib. And if they have undiagnosed WPW, which is very possible, then that can put them into VFib. Adenosine is not a treatment for AFib. Adenosine for AFib is something they put in the narrow complex tachycardia protocol for dummies. Like, they don't think, that protocol doesn't think much of us as responders. Like, can we not identify AFib? And if we can, do we not know that adenosine doesn't convert AFib? And tell me why you're wanting to convert AFib in the first place. So if you have AFib with RVR at a rate of 130 or 140, chances are they're normotensive or even a little bit hypertensive. And in that case, conversion isn't really called for unless the patient has severe chest pain or they're altered or something. Also, you have to ask yourself, is this new onset or is it chronic? If it's new onset, they're probably not taking anticoagulants, and you probably don't want to convert that because that clot that's sitting there in the auricle of the atria is going to be happy to come out once that atria is subject to those atrial pressures again. And in somebody who is in chronic AFib, have they been compliant with those anticoagulants? Again, same problem. So if they're hypotensive, which is rare in atrial fibrillation, then I can understand. But maybe even try a fluid challenge first. If it's so rapid that you're concerned, if your AFib is in the 180s and 200s, then it probably is associated with WPW. WPW is usually responsible for those AFibs we see getting up in the 200 range and over. And so in that case, I wouldn't want to use adenosine. And in those rates, if the patient's got chest pain and they're really just not doing well, cardioversion would be indicated anyway. Yeah, cardizem drip. I said cardioversion. I meant to say cardizem or cardioversion. That's correct. But still be careful with that cardizem, because once it slows things down and that patient gets normalized atrial pressures, if they haven't taken anticoagulants within the last 24 to 48 hours, now again, you're at risk for loosening that clot. So ask yourself why you're converting that AFib. I think it's actually pretty rare that AFib requires conversion in the field. I have had adenosine as an intervention. It's something, I tell you, whoa. That's why my preference would be cardizem to convert some sort of SVT, like a reentry rhythm anyway, because it works just fine and it doesn't subject that patient to that feeling of impending doom. So it's 1:51. I'm going to call it here in about 10 minutes. I saw a flutter in the field for the first time in a long time. Clear as day, shark tooth waveform. Yeah, or that sawtooth. I think you're combining the shark fin in end tidal and the sawtooth in A flutter. But yes, the sawtooth waveform is very unmistakable. And if you think you're seeing A flutter, but your R waves you just don't have a lot of amplitude there, one of the best things you can do is what's called a Lewis lead. And you can Google that, the Lewis lead. It's where you kind of cluster your precordial leads in this certain pattern on the chest, and it hyper focuses the analysis of the P wave. And so you get much taller complexes. And so you can get a better view of the P waves that way. Just Google Lewis lead. Anytime you're not sure you're seeing P waves, you should do a Lewis lead. Yay, TikTok let you go live. Yeah, last night I got banned midstream saying that I was engaging in bullying and harassment, but I filed an appeal and thank you, Dusty. I filed an appeal and it was overturned almost immediately. But that was scary, man. I was like, what did I do? I don't know if it's an algorithm or if just somebody, was upset that I disagreed with them or something like that and, caused some sort of reporting thing. I have no idea. It happened to Greg with Shade Tree Cardiology. It happened with Jenna Roxbury. It happens. And we're all three people that, have very strong opinions, although I think that I tend to disagree with people in very polite ways. Good content. We speak the same language. Sometimes it's lost in text. Yes, absolutely. We imply a tone to people, in text. I have to actively work on my tone, though. I'm from northern Jersey, and people speak very directly to each other, very frankly, without pulling punches, and I really had to work on that in the South. It doesn't come across the way I think it's coming across in the South, that's for sure. And I have resting bitch face, too. I've had to work on that. This is my general face at work that you're going to see. And that's my happy face. So I have to really work on smiling, too. Although wearing masks all the time has really helped that because people can't see me frowning. So I think we've reached a good spot. The questions have kind of dried up, so this is a good spot for me to stop. And I've been live for a long time. My mouth is getting tired, and I have some things to take care of in the house. So I really appreciate everyone keeping up with me. I appreciate the follows. I appreciate the encouragement. And I appreciate all of you. Please go out there and have empathy for your patients and provide compassionate care. Everyone be safe and have a great afternoon.